You'll have to hear my voice is what I'm saying, so don't expect you to hear any projection. This is for online. Thanks for the patience and for a pretty full room. I appreciate the attendance. We're really happy that we have Dr. David Diaz Sanchez all the way from the East Coast of the US. He's someone who I've actually wanted to have come speak for quite a number of years. I could honestly say that of all the scientists, he's probably the one that is most influenced what I'm currently working on, the project that some of you know of. I won't go into, but he really set the stage for that. So I'm really grateful for your coming. He trained in terms of his PhD at Guy and Mark's Hospital in the UK. Then went on to the University of California in Los Angeles, where the work I was alluding to was done. Really, I think, incredibly important work showing that diesel particles along with allergens really had a synergistic immunologic effect. And I think there's a lot of important implications of that. And then because of his good work, he went on to the EPA in North Carolina and became the head of the clinical trials unit there, the clinical research branch, and continues to do good work there. So I'm going to just let him take it from here, and we'll try to leave a little time for questions at the end, and I'll come up and moderate at that point.
Thank you very much. It's a real pleasure. Thank you, Chris. It's a real pleasure to be here in Canada. Or America done right, as we call it. So as Chris says, I used to be in Los Angeles, which with lots of trucks and lots of pollution. And then I moved over to study pollution at the EPA, which in Chapel Hill, which is on the other pit, which sounds counterintuitive, really. In a lot of the stuff I'll talk about is obviously focused in the States. About half the people in the States live in counties that have unhealthy levels of either ozone or particle pollution. And people, they rank each counties, and about 154 million people live in counties that get an F, a failing grade. So air pollution continues to be a serious problem. We've had great strides over the last 30 years. 50 years, but it continues to be an important problem. And one of the issues of it is that it's not equally shared. If you look at the impact of air pollution, and this is just exposure, you see that African Americans are at increased risk to exposure because of the places that they live than Caucasians. So the issue of air pollution is not just one of health, it's one of environmental justice. Well, the Clean Air Act, and I can say it here, we get beaten up a lot, the EPA, down quite often. The Clean Air Act was put in 1970 by President Nixon, last amended in 1990, and there was once, a few years ago, there was an estimate of which law has produced major economic benefit in the United States, and the Clean Air Act came out to be the most cost-effective piece of legislation ever done in the US. And the reason for that is that it's estimated that in 2010 that PM caused 160,000 mortality, and that is with reductions in air quality in particulates. With increased pollution, it would have been much higher. So how does the research really fit into this? The way standards are set is a long process, but a key element of the process is that there's a document written which is called the Integrated Science Assessment, which basically takes the key pieces of research being done in this field and puts it into a document, and from that it's critiqued, and then from that a risk assessment is done, which puts a quantitative number and says, we think that this is the number that should be that you should use, meaning that ozone should be at this level, particles should be at this level, and that would be the most protective for human health. One of the key things about the Clean Air Act is that it's written that it says it's to protect the health of all individuals, not just the majority, but just all individuals. Now that's an almost impossible task, but the reason that's important is, as we'll go through, you'll see a lot of the science shows that pollutants do not impact everybody equally. Some people are at special susceptibility to it. And the challenge we face is trying to set regulations to protect these susceptible populations. So the health, I come from a health background, and I come from a health and exposure lab. And the research we do is there to do basically three things. It's to look at the current standards and say, are they protective of human health? The second one is to provide evidence to support the standards. Is there a scientific basis for setting these standards? And the third one is to provide evidence and to inform people, especially at-risk populations. And so I'll give an example of each of these as we go along. I could provide many, but I will give an example of each one as we go along. In particular, I'll talk about human studies at the EPA. There's been an active human studies program going on since 1973. And this slide's a little bit out of date. There's probably more than 6,000 human volunteers have been studied, and we've never had an adverse effect on a volunteer. And these studies have been critical in setting standards. For example, it used to be in the country that we used to have a 1-hour standard, but then research done by Folensby, who actually used to be here and then came down to the EPA, showed that what a critical measure was 8-hour exposure was as important as a peak exposure during the day. And so research has gone on to help to set these standards. This is one of chambers. We have 9 chambers down at the EPA, and where we do controlled human exposures to different things, to Chapel Hill air, which we get the air from outside and concentrate it 30-fold to diesel exhaust. So you have a diesel chamber here as well. Wood smoke, gases, we've done different things. And people sometimes ask us, well, isn't this dangerous? And you're saying that particles are dangerous to people's health, and yet you're exposing people to particles. It's important to understand the difference between a population level risk and an individual person's risk. Typically, we expose people to air in our chambers, and we've calculated that the risk for them having a health outcome like atrial fibrillation is about 1 in 400,000 to 1 in a million, or 1 in 2 million. That's not to say that these particles don't present major health problems. They do. But the reason that these risk is so low in our chambers, A, because we only use healthy people, or even if they're older or susceptible, we make sure they're very healthy. And secondly, the odds of you something happening in a 2-hour period is that low. But remember, you're breathing in air every day, so you're rolling those dice continuously. So, you live through 1 million 2-hour events. And so obviously your odds are much higher. The controlled study's been done since the 50s there, and it's been done to a variety of things. So let me go to an example of the first one, information to set standards. Currently the standard in America is for ozone. It's very controversial. It's 0.075, and there's a lot of debate about whether it should be lowered or not, and there's lots of lawsuits. One of the things you learn working at the EPA is that you're the subject of constant lawsuits. The effects of 0.08 ozone, what's familiar ozone, is very well documented. You see decrements in lung function, markers of inflammation. There's a big debate about whether we should lower this or not. And one of the issues becomes, should we lower it down to 0.06? At the recent scientific advisory meeting about the standard, 3 topics came up. One of them was, what is the real background level of ozone in the country or in the world? It's actually a far more difficult question than you think. And second was, what levels causes health effects? And the third one is, we'll come on to later. So there's very few studies showing the effects at levels below the current standard and what the health effects are. So this is an example of a standard setting study. We took 59 subjects. We put them in the chamber. They're exposed to clean air or they're exposed to ozone under the current standard for 6.5 hours. They do a little bit of exercise. We separate exposures by at least a week. We do it in the low ozone season, and the reason we do that is we don't want them coming in and they've had a high dose of ozone and it confuses everything that we do. And one of the things we've done is stratify the population on genotype. What this means is there's a good literature now that suggests that half the people in this room have an enzyme, have a gene for an enzyme called GSTM1, and half people cannot make this enzyme. And it's been shown in many studies that this enzyme is actually important in protection against the effects of air pollution. And so one of the things our air office is thinking is, should we take genetics into account when we start setting the standards? So one of the things we did is look at the people in our study and try to balance them, so half had this genotype and half didn't. So the first phase was we took 30 subjects, exposed 15 males, 15 females, do a lung function before and after, and we do sputum, which means we look at what they produce in the upper airways, or in upper going down to about here airways, and look at so the upper lower airways, and look at responses, inflammation there. And in the second phase, we do the same, but with a lower concentration of ozone. Don't worry about the details. This is, and I wonder if this is going to work. It never works for me. Unfortunately, my movie never works. This is actually one of my postdocs blowing into this, and what she's doing is the lung function test. This is not what they're not breathing in the ozone in here. What that big chamber you see is that's where they're breathing the ozone. It's a chamber about half the size of this room. What she's doing is doing lung function, and if you could see it, which of course you can't, you would see the coordinator telling them to blow in there, and we look at how much they can blow in 1 second out, and see before and after. And what you can see is that even when you're exposed to these very low levels of ozone, below the current standard, you still get a change in the ability to blow out. So you get a change in lung function, even at these very low levels. Now, one of the criticisms of this is that the decrement, how much it drops, is only 1.5%. That's not clinically relevant, we've been told. And it's true, it's not clinically relevant if you, but you've got to, again, extrapolate this from individuals to a population, because it's not the same. Apart from the one that goes up, which was an aberrant result, the person had a response to clean air, but we always show all the data. Everybody goes down, but some people, you see, go down a lot more than others. And so if you extrapolate this to the population, you'll see that although the majority of people will drop down by 1.5%, it's clinically not relevant. And these are healthy people. There are people at the extremes who drop down 10%, 15%, 20%. And if you look at this in terms of asthmatics or people who have difficulty breathing in the first place, this is a serious problem. One of the things that it's well studied is that as you grow older, this health effect actually goes down. So all you young guys have actually more drops in lung function than older guys like Chris and myself. But if you extrapolate that further, think about, studies are never done on children, but if this is the effect, if you see much less effects in the elderly and than in the young, if you extrapolate that further down to the children, you'll see that you can think that they would have even greater effects. And it's not quite true that older people don't have an effect. It's just that they drop down. But these people who are hyper responders, you see those less in the older people, and you see these hyper responders more in the young. And so we think that in the children, you'll see a lot of these hyper responders will have a really big effect. And we see cells coming into the airways as well after this. And when you look at genotype, I'm going to go through this. When you look at genotypes, you also show that those people, although it doesn't seem to have an effect on lung function, if you're deficient in this enzyme, you also have more inflammation in your airways. So you don't have an immediate response to the ozone, but it sets you up for future responses. So these people who don't have this gene, and a functional form of these genes, and again, that's about 30 to 50% of the population, are at increased risk. Currently, the standard set on the whole population. So the summary is that these these low levels of ozone have a small but significant drop in lung function, and you get inflammation. And so this type of information is used in the integrated science assessment, and it's used when to think about should we lower the standard. And these types of studies have been one of the driving forces in setting these standards at what levels. So we're talking about the airways. Let me talk a little bit, another example about the scientific basis for standards, because it's not all just doing studies where we look at those different levels of doses. That would be pretty boring, to tell the truth. Important science, but pretty boring science. Cardiovascular disease. Cardiovascular disease presents a new challenge to air pollution scientists. For many years, people just focused on the upper airway. You breathe something in, right? And you breathe in a particle. So why would you expect to see anything in any place apart from the lung? I mean, a particle can't go to the heart, can it? Well, there's some people who think it may do, but the thought was, why should you be getting effects outside the airways? The epidemiology studies shows that just for a few days after exposure to particles, you can, at elevated levels, you can significantly increase the risk of heart attacks and ischemic heart disease. And this is not just a study. There's data now from over 100 cities around the world that's shown a real remarkable consistency between air pollution and death from cardiopulmonary death from particles. Famously, a study called the 6 City Studies looked at air pollution levels in 6 cities. Yet, it doesn't make any biological sense. And so the concept was, how could a particle affect the cardiovascular system? So that has been a key focus of the studies done at the EPA, both human studies and animal studies, over the last 10 years. And it's probably one of the greatest findings over the last 10 years is to show biological plausibility for how particles can affect the cardiovascular system. How can they affect areas outside? For those who understand these things, the thought is that it can cause repolarization, meaning it can change the electrophysiology of the heart, how the heart beats. There's another thought is that it can cause inflammation, and that inflammation can cause thrombosis, can cause rupture of plaques. We, now using the royal we here, did a study about a decade ago, which shows that if you look at elderly individuals, and these were healthy elderly individuals, again, we only expose people at the lowest risk. When you expose people to concentrated air particles in Chapel Hill, but just concentrated 30 times, you see that their heart rate variability changes. What's heart rate variability? This is how variable your heart rate is. And the reason that's important is that you want the flexibility to respond to stimulus. And if you don't have that variability, you can't respond to a stimulus. So decreased heart rate variability, it's a bad thing. And so this study showed that, in fact, when you're exposed to these particles, they decrease heart rate variability. The good news for you guys is that it seemed not to have an effect on young individuals. I say you guys, I lump myself in with you guys, right? But so young healthy people exposed to the same levels didn't seem to have this decreased heart rate variability. I'll tell you the bad news a bit later on. So again, unfortunately, that's a study done with fine particles. Now, there's different types of particles. There's coarse particles, which are large, middle, you should know this, middle particles, what called fine particles, which is respirable, and ultrafine particles. And recently, there's been a lot of interest in these ultrafine particles because they come from exhaust, they come from traffic, and there's been a lot of concern about people living near roads, etc., and how they may be at increased risk. So the bad news was that Jim Samet in our group did a study where he exposed individuals to ultrafine particles. When you're looking at ultrafine particles, you have to go by particle number because they have very little mass. And what he showed is that when you expose the unhealthy individuals to ultrafine particles for 2 hours, they again had this change in arrhythmia. So indicating that if this had been a susceptible individual or prolonged, they would have had changes in the heart that would have made them more prone to adverse effect. Now, we're very, very cautious in where we are on purpose. Other people are less cautious, and I'm not saying this as a bad thing, it's just the way different attitudes. In Nick Mills in Europe, in Australia, in Scotland, nearly the same place. He exposed people who had had a heart attack and made them exercise in the chamber. Now, my IRB would just laugh at me if I tried to do that, but he managed to do it, and he took all the proper precautions, and he's a very good scientist to make sure that nothing happened to them. And what they showed was that when you expose people to diesel exhaust, who have had this heart attack, so have this propensity to have an effect, they saw ischemia, sort of the beginning stages of a heart attack. It was completely safe, but it was the indication that this could have caused, if this had been prolonged or greater, they could have gone on to develop a heart attack. So again, adding biological plausibility for the effects of a particle to cause a disease. These particles also don't just affect the heart, but they affect the circulation. And there's studies clinical studies from panel studies. And these are studies where instead of putting someone in the chamber, what you do is you, for the epidemiologist amongst you, I apologize if I'm patronizing. But what they do is you're looking at variations day to day or minute to minute, or depending on how you're doing it, and comparing that to responses in the blood 1 hour afterwards, or a day afterwards, 2 days afterwards, and seeing do they correlate one with another. And he's shown that, and Ralph Delfino down in California showed that indeed, if you look at that variation, you see that people with coronary artery disease, their blood is changes in the blood that causes factors that could lead to thrombosis if they're at high levels change. When we do the same studies in the chambers, we again also see that if you expose people to ultrafine particles, you increase these factors in the blood that if they were very elevated, not these levels, these are low levels and transient, but if they were at higher levels and prolonged, that would cause thrombus, meaning, and when these break, you could cause thrombosis, atherosclerosis, etc. So, for particles, this is just a thumb sketch of what's been shown for these different coarse, fine, and ultrafine particles. When you stick somebody in a chamber, you never see, and very few people do see changes in actual pulmonary function, meaning that with particles themselves. But you do see inflammation setting them up for future disease, and you see changes in both the heart and the vasculature. So that's great. Now the thought is a particle sticks around there, right? And either the chemicals leach out into the periphery, as you know better than I. The particles are surrounded by different types of chemicals. Some of these can leach out if they stay in your airways for 24 hours. They can leach out into the periphery and have an effect on the heart or other circulation. Or you course a change there that can, those factors go out into the periphery. Ozone, though, is a different beast. Ozone is a highly reactive gas, hits your airways, and within 3 seconds, it's gone. Yet, epidemiology studies, and this was a big point of debate in the recent scientific review of whether we should change the standards. Well, ozone has now been linked with mortality. A study by Michel Barr shows that when you increase ozone by 10 parts per billion, you get an additional 3,700 premature deaths. How can that possibly be? I mean, it doesn't make any sense. So, although the epidemiology data was there, it was the industry and other group scientists have dismissed these studies, saying there's no biological plausibility for this. So we just published a study, again, and I won't go into the details, but again, showing that if you expose young, healthy people to ozone, you can indeed see changes in the way the heart beats and in changes in the vasculature. The way it does this, people are working on now, and it's a big focus of the research, animal models and human studies, to try to understand it. But the reason this got published recently and got a lot of press attention, and the reason for it was A, because Bob Devlin, who heads it, is a good spokesman, but B, it's because it's the first study that really shows biological plausibility, that these things really do happen, and ozone really can affect the vasculature. And so studies at the moment are trying to understand why, and if I had to guess, I would say it's neurogenic, but it's premature to understand why. So the other thing to understand is I've been talking about air pollution, but one of the things we want to do is set ourselves up for the future. There's a lot of work that has been done about air pollution and climate change, and it's something that obviously people are very interested about. And the concept is that it's a cyclical. When you talk about the relationship between air pollution and climate change, it's an interrelated process in that you can have air pollution, black carbon, etc., which promotes climate change, and changes in the climate are predicted to lead to increase in ozone, etc. And all of these have a health effects. This slide done by my postdoc, who's a great scientist, but she sucks as an artist. So, where do we come in, right? Where we come in is we're trying to understand the health implications of this, and one of them is, yes, you've got a change in air pollution levels, and therefore you've got a change in the amount that somebody is exposed to. But the other thing is there a direct effect? We know there's a direct effect of air pollution on health. Is there an effect? And we know there's an effect of heat on health. So what is the combination of the both on an individual? But another way, does somebody respond the same to a pollutant at a low temperature and then a high temperature? This is just a graph showing temperature range, and this is how ozone increases with temperature, roughly. Well, nearly all the studies that have been done to date, in fact, all the studies that have been done to date, have been done at 72 degrees. Don't ask me what that is in centigrade, I don't know. But somebody will come up and be smarter than I will tell you. Which is okay, but that's not when you really see the ozone. You see ozone at much higher level. Normally, ozone goes up when it's hot. So we've just done a study called Tropicos. Again, our nurses come up with the name. They're very inventive. Asking the question, is there a difference in people's responses to ozone at low temperature and high temperature, given that more and more places are predicted to have extreme weather events? This is an important thing for setting regulations in the future. So what we try to mimic is a heat wave. Now, 92 degrees is not a heat wave in South Carolina, I can tell you. Probably 72 may be up here, but 92 is certainly not in South Carolina. So we do these all in the winter, and at the same time we look at look at data from different cities and look at through database mining, look at different cities and look at pollution. And the things didn't come out well here. But what this is supposed to show you is the darker colors is supposed to show you the increase in mortality. This is used from a database. And what it shows you is it depends where you live. If in Los Angeles, the hotter it gets, the more mortality increases. Whilst in Newark, the colder it gets, you get more mortality. So this is interesting, but it's very hard to understand what it means. And there's reasons for that. People may put their air conditioner on at high, etc. So that's why we try to understand what is the effect of temperature on somebody's body through chamber studies and try to understand how people respond at different things. And again, what this shows you is that when you expose people to either cold or hot temperatures, their lung function both declines. So they don't really change their lung function if you're in a hot environment or in a cold environment. However, as I mentioned, when you're exposed to ozone, you get changes in these markers in your blood, which predisposes you to thrombosis. And when you do the same study at high temperature, which is in the red appropriately, you see that these increase, meaning that although this data is still preliminary, but what it suggests is even though you're not going to have changes in your breathing patterns and your response to ozone at a low versus high temperature, you're going to have these cardiac changes are going to be more pronounced at a higher temperature. So as we predict the future and we try to understand the effect of climate change, one of the things we have to think is, are these standards going to be protective going forward, or do we need to think about the climate, think about these standards in the future, for the future? So briefly, at-risk populations, and we could give lots of examples, but this is an example of looking how we try to understand which groups are at risk and why. And this is a diabetic panel study, and previous studies have shown that there's a quarter of the population that have pre-diabetes, metabolic syndrome. And this continues to be an increasing problem. You've all read about how children are now getting diabetes, etc. Studies have shown that people with diabetes are more susceptible to particles, even if you compare them to non-diabetics with cardiovascular disease. So we're trying to understand why this could be. Is this real? And why this should be. Again, this is an example where we wouldn't put somebody in a chamber like this because it's a health risk. So we look at their day-to-day variation. So we look at how changes in the body correlate with outdoor activities. One of the things we do is look at a thing called endothelial cell dysfunction, and I'll talk a little bit about that. But we want to go further and not just try to understand, is pollution bad, but try to understand what components of pollution are bad for you. So it's great saying particles aren't much bad, but I mean, it's fine saying particles are bad for you, but we're really trying to understand what particle, what component of that particle is bad for you. Where do these particles come from? And why do they impact these susceptible individuals? So this was a study we did where we took 22 people with diagnosed diabetes, older people, and looked at, they were mixed ethnicity, and followed them around for 5 days. They had a Holter monitor, personal exposure monitor, and we take various measurements throughout the week. We measure rooftop. We've got a monitors up on our rooftop where we collect particles. We look at PMS. We look at metals by XRF process, and I'll talk a little bit in a moment why this is important. And look at meteorology. And then we do these statistical models. I only put this here for those who are statisticians who will understand it, and those who aren't won't. But the key to understand from here is that we look at confounders in this system. It's not just trying to look at a straight correlation. You include things like air temperature, relative humidity, pressure, days of the week, anything we can think of, and they're put in these statistical models. And you look at these different lags. One of the things we're interested in is the vascular endothelium. This is a type of cells, and it maintains your vascular tone. It regulates thrombosis, and it's mediated through inflammation. And there's several conditions that have been associated with impaired endothelial function. So although we're using diabetics in this study, it's got application beyond diabetics. And there's lots of risk factors for it. Aging, which I don't know what we can do about that. Tobacco use, obviously. Sedentary lifestyle, I'm guilty of. And one of the thoughts is particles a risk factor that contributes to it? The way we do it is we take it's always good to have pretty pictures in a talk. So, or the ugly pictures, whatever you want to call them. So what we do is we take an ultrasound of someone's brachial artery, and we cuff them. We put a cuff there. We look at the brachial artery, and we look at the flow. You hold it there. You squeeze that area for about several minutes, and then you let it go, and you see the flow through it. And you can measure the dilatation, how much this brachial artery changes. So when you do studies, you see that you see decreases, that you see changes in brachial artery dilatation, meaning in the flow, meaning that you have restricted flow in blood flow, showing that exposure to particles can reduce your blood flows and therefore reduce your increased chance of vascular injury. And you can, for those of you who like immunology, you see changes in these pro-inflammatory factors that are related to vascular health. And so these have different lags, so it's not an immediate effect. When you're exposed to particles, you have an effect that knocks on for a couple of days, which is why when you're looking at things like mortality, it's important to not just look at today was a bad pollution day, how hospitalizations or mortality the next day or the same day. You have to look at a couple of days later. Again, what this slide shows is, again, those people with this type of genotype, which, again, half of you don't have, so tough. They are at increased risk. So this is a little bit for an atmospheric chemist amongst you, but it's a good illustration of why we work together as health scientists. We work with our friends in the exposure sciences and with our friends in different disciplines. Typically, when exposure, people who look at exposure particles and exposure in individuals, what they do is look at XRF, and they look at all these different, which is a process by X-ray on filters, and they look at they can look at all these different ions on particles. Except, as biologists, we keep saying, that's great, but we're not really interested in those. We're interested in what's water soluble because you may be looking at these metals, but we're interested in things that come out of water, not things that leach out with acid, because we don't have that. We're not really concerned with health effects for the creature in aliens. We're more concerned with individuals. The reason what you can do is by looking at the cell composition on the cell surface, is be able to group these. So you can say, these come from wood, these come from tire, these come from breakware, etc. I'm going to sort through this in a matter of time. How are we doing for time, Chris? Yeah, so basically what this shows is that when you're looking at water-soluble metals, you can lump these together in different families, and we see correlations between different types of, very many different types of metals on the cell surfaces. If you had only done this through XRF, the typical methodology that is used, and which is used around the country for speciation you would really be missing a lot of this. So the thing to get from this is to understand that one needs to, what's good for one discipline isn't necessarily good for all disciplines. The chemists like this procedure called XRF because it tells them they want to look at certain questions and atmospheric transformation, etc. But for biology, it's probably not sufficient, which is just an illustration of how we need to work across disciplines to get what we need. So very briefly, the other thing we are in charge of, we need to do is telling the air office what things lie ahead, what we should be worried about coming up. There's some things that are obvious. Some things not so obvious. I won't go into a pile of studies we're doing, looking at biology and epigenetics, etc. But one thing that has gained a lot of interest recently is multi-pollutants. At the moment, all standards are set on individual elements, ozone, particles, and NO2, for example. Yet, and when we've done studies in the past, we expose people to ozone particles. But nobody breathes that in. We all breathe everything in the context of something else. So a report has, in 2004, said this is an important thing in the future. We need to address multi-pollutants in the standard setting process. Not that we have to set standards based on these, but maybe ozone is safe at this level, but if you see it with PM, it's no longer safe at that level. You need to reduce it. Or maybe it's safer because it reacts, and you need to take that into account. So we've started doing this. This is a study we've just completed, exposing individuals to both ozone and diesel. And you either expose them ozone and diesel together, which is interesting because chemistry changes completely, and you produce a lot of NO2, or you can expose them sequentially. And you're asking two different questions. If you're putting them together, you're asking, how does different atmospheres cause these different health effects? If you put them sequentially, you're asking, does one pollutant prime you for another pollutant? And you can think of lots of examples. You're driving, ozone's low in the evening, but you're driving home and you're exposed to lots of particles driving home. Next day, you get up and you're exposed to a bolus of ozone. And so what we saw in terms of lung function is that, as we've mentioned before, diesel doesn't change your lung function at all. Ozone does. If you give them both together, you have this synergistic effect, meaning that the diesel makes your response to ozone worse. And this happens if you do it either give them at the same time, or if you're pre-exposed to diesel and then give them the next day. And you see that if you do that, you get a change in lung function, and we're looking at inflammation at the moment. But it shows the concept that two pollutants together are not the same as pollutant A plus pollutant B. You need to think about the relationship between them, not just the chemistry, but their effects on biology. And when you're trying setting standards, you've got to try to think about these all together. This is just a flavor of the things we do. And I haven't really touched upon it, but this is the whole paradigm here is not just to identify common pathways in humans and animals, but really to go forward and translate this into a public health message. When we find things out, we have the effects of these, we go out and try to go into the communities and try to explain this. My boss, who's a cardiologist, has a program called the Green Heart Campaign, which targets people at risk and explains to them the environmental effects, environmental impacts on the heart, and what you can do about it. We have a thing called the AQI, Air Quality Index, which warns people. We've done some studies now suggesting that even if your exposure is the same, if you're poor, you are at increased risk, even if you've got the same exposure. There's something about being poor that has that. And so we're considering things like, should we be doing advisories based on not just exposure, but on risk? Now, I'm speaking personally, they're not for the agency, but it's something to think about. So hopefully this gives you a flavor for all that we do. And I welcome anyone to come down to our facility at, down in Chapel Hill, which is nice, but nowhere near as nice as this campus. So thank you.
I'm also including the online community, but I don't need to go too far because Tom has a question. So I'll let you ask the question, and then I'll repeat it. Do I need to repeat it to the online community? Give him the microphone. And then when you're done with your question, you have to turn this one off, and he turns his on.
Thank you. Lots of intriguing and interesting information. I just want to pick on a minor issue that you dealt with, the issue of the interaction between heat and ozone, which has been described by people, including me, up to 10 years ago, epidemiologically. But so there's plenty of evidence that look at what you're saying, but I really wanted to ask about the way that you measured it, because it may not be the temperature itself, but change in temperature that really provokes the effect. And measuring that in Los Angeles in the winter, as an example, or North Carolina in the winter, may be very different than measuring the effect of a 95 degree Fahrenheit exposure in the summer. So I wonder if you'd considered that and considered perhaps acclimating people for several hours before testing them in order to look at whether or not it was the temperature themselves or the kind of shock of being exposed to a higher temperature that was provoking the interaction between ozone and temperature.
An excellent question, and I may not have made myself clear, but that's exactly the point, which is we did it in winter on purpose so people weren't acclimated. One of the limitations about clinical studies is small studies, and you can't do everything. And it's very clear that a 20 degrees increase in Los Angeles is, let me put it, 92 in Los Angeles is not the same as 92 in Vancouver. It's not even clear that a 10 degree increase in Los Angeles is the equivalent to 10 degrees in Vancouver. But our goal was not to mimic a hot summer, but was to mimic a spike in heat over a day. What happened, and that's why we did it in a cool temperature in the times when it was all cool, and look at what this differential is. I agree. I think it is that differential that is important. In fact, some of the data we have from the epidemiology that we're working on seems to suggest that it may not even, it may be the peak exposure that may be important. So your point is well taken. Yeah, the effects is probably not due to the heat per se, but in changing the differential of the heat. And certainly, if we repeated this in summer, we might actually, in North Carolina, we may actually be cooling them down by putting them in a chamber. But if we repeated it in somewhere else, you would see a difference. And that's why we think that when you're looking at this association between mortality and ozone and temperature, the relationship is different in Los Angeles than it is in New York, than it is in New Orleans or whatever.
Yeah, the question was asked midway through the presentation in regards to the graph that showed the decrease in FEV. She was just asking what the red dots referred to.
So we'll go with Bianca. I'll give you the microphone. I'll go through here. I feel like a talk show host.
Great presentation, very informative. I guess my question revolves more around your individuals when they come to your exposure chamber. How much do you control where they are before they come to your exposure chamber? How long they acclimate? How much do you take into context their exposures before they come in?
Yeah, I mean, it's a great question, and the answer is we try to control their environment. We tell them, don't get exposed to this, don't get exposed to that. We do cotinine measurements, etc., etc. It's a limitations, but unless you can, and we do sometimes stick a monitor on them for 24 hours beforehand to look at a personal monitor. I will tell you, it's not a great limitation in Chapel Hill, but I used to work in Los Angeles, and I had a diesel chamber there. Well, Henry Gon, my colleague, and I had a diesel chamber there. And to get to his place, you used to drive up this freeway called the 710. Well, sometimes we were seeing all these effects before they even got into the chamber, because the commute up there was giving them as much of an exposure as the chamber. So it is a very good question. It's a limitation that we need to these days.
Thanks, great presentation. And my question builds a little bit on what Tom was talking about, looking at the association of ozone and temperature. And you may not have an answer to this question, but physiologically, I'm wondering about the differences in the combination of ozone in the heat compared to a thermoneutral environment, just due to an increased dose of ozone because of elevated breathing rates associated with core temperature increases.
Yeah, it's a good question. The answer is, you're right, I don't know. But I will tell you what we do is control their breathing in the chambers. So they exercise. They do intermittent exercise in the chambers. And we are monitoring them. And we adjust the reason you do exercise is to increase the delivery into the airways, because typically somebody's not sitting down, unless you're me. And then, so we do, that's when they really get their exposure to the ozone. And by monitoring their metabolic rate, we actually adjust their exercise based on that. So we do try to control for it. Now, there could be different breathing patterns, etc. And we just don't know. Whether exactly we do. Yeah. Absolutely, and that's why we alter their load, the exercise load they do, based on those factors to try to control for
that. How low can you go with respects to regulation of ozone? I guess from a policy perspective, government perspective, considering that you said that the Clean Air Act had a major economic benefit for sure. I'm just playing devil's advocate, but as you increase the regulations, probably the costs are going to be increasing to enforce those regulations. And probably there's going to be some diminishing returns with the money you put into it. So where's the balance, and where does the EPA stand on the balance of how far we lower those levels?
We produce the substance in a completely different body that puts the policy. That may be evasive, but hey, if you ask me over a beer, maybe I'll tell you differently. But as an EPA person, I will tell you that we just provide science. It's up to the administrator to set the policies. We have, as part of the EPA, there's an office of, you'd think there'd be an office of cost and benefit, but they just broke it down to an office of cost and one of benefit. I don't understand. Obviously, someone made sense to someone. And to actually look at exactly those types of issues. And they do a lot of these calculations to see what is going to be saved and what's the cost of these things. I will say, though, that the Clean Air Act, if I think I'm right, is not allowed to take cost into account. So it's not our role to determine the cost of this, of the health benefits. So if you're asking the question, how low can you go before you hit background, and therefore that was a third of the questions. I mean, it depends what background is. And some people claim background is 0.05. Some people claim background is 0.02. I mean, it depends where you measure it, what you think it is. It depends where the background comes from. If the background is coming from anthropogenic sources, yeah, that's the background, but it still comes from anthropogenic sources. If you believe it comes from trees or other natural sources, then it's not much you can regulate on those. It's a very difficult question, but as you go lower and lower, the question becomes, is there a threshold? And at some level, theoretically, is somebody going to be hurt regardless of the level it is? Those are tough questions to answer. That's why we pay the administrator big bucks to get in front of Congress.